So the next presentation is Dr. Kavitha, best paper of Rajasthan Ophthalmic Society, Bowmans membrane lenticule in peripheral ulcerative keratitis, a novel technique.
Thank you, ma'am. Good morning to all. Today I am presenting a paper on Bowmans membrane lenticule in peripheral ulcerative keratitis, a novel technique. Bowmans membrane is a second layer of cornea which is acellular, 17 to 21 micron thick. It harbors subepithelial nerve plexus and obstacle to passage of microorganisms. It also provides tectonic support to cornea. PUK is an immune-mediated crescent-shaped destructive inflammation of juxtalimbal conjunctiva and corneal stroma. Hallmark features of PUK is formation of peripheral gutter and stromal destruction, presence of WBC-laden overhanging epithelial margin, and juxtalimbal conjunctival inflammation. The inflammatory condition results from host autoimmunity, peculiar anatomic and physiologic features of peripheral cornea, and environmental factors. Management of PUK is multidimensional and require ulcer healing, perforation management, and stopping further males by reducing inflammation. Surgical management is done by amniotic membrane, lamellar patch, banana graft, and conjunctival resection. Pitfalls of amniotic membrane is non-transparent and flaccid and lacks tectonic support and dissolved in 2 weeks. Thus not giving a permanent stable scaffold. Complete corneal grafting, banana graft and lamellar graft reserved for large perforation and advanced disease. Corneal grafting has higher chances of rejections. Bowmans membrane lenticule is a very strong, transparent, acellular, natural and innate structure and gives a stable surface and contour for epithelial growth. It is tucked under the ulcer margin and help in filling and healing of gutter or larger defects. It has been used for stabilization in advanced keratoconus cases and also in perforated corneal ulcers. Pathogenesis of PUK is immune-mediated, which activate complement pathway and leads to vasculitis and release inflammatory cells, which accelerate and propagate the peripheral corneal destructive process. Triggering factors are trauma, infection, and prior corneal surgery. We studied healing of PUK using BM lenticule as a substrate and estimate the improvement in best-corrected visual acuity compared with preoperative values. These are the inclusion and exclusion criteria. Our study is hospital-based single-center prospective interventional study. Sample size is 30 cases. All patients underwent full ophthalmological evaluation. Surgically, we tucked the Bowmans membrane underneath the ulcer edges after making a recess in anterior 1/3 of stroma of ulcer edges. The mean epithelialization time was about 2.3 weeks. The mean best-corrected visual acuity increased from 0.118 to 0.311. The mean corneal thickness was increased from 233.60 to 433.667, which is good. These are the graphical representation of best corrected visual acuity and corneal thickness. These are some slit lamp pictures. PUK has a unique disease pattern due to peculiar features of peripheral cornea. In our study, 30 patients of PUK underwent BM lenticule grafting with a high percentage of success. The mean time taken for re-epithelialization after surgery was about 2.3 weeks, which is in concordance with a study done by Chaudhary et al., who utilized Bowmans membrane in setting of small corneal perforations. Vonik et al. In their study observed that Bowmans layer prevented ectasia and provided cornea with safe and tensile strain, thus delaying progression in cases of keratoconus and keratoplasty. The disease arises due to self-destruction by immune system, making it much more difficult to treat and makes it liable to recurrence even after treatment. Bowmans lenticule stayed in tucked in place and giving a stable surface and contour for growing epithelium. It helps in early wound healing, inhibit vascularization and abnormal growth of fibrovascular tissue. It also promotes nerve growth. Being largely acellular, it does not incite any foreign body reaction like graft versus host reaction or hypersensitivity reactions. Bowmans membrane is a strong layer that provides a scaffold and growing epithelium and regenerating nerves. It also facilitates epithelialization and stabilizes the ocular surface. The main outcome measures and upsides of this surgical modality are fast wound healing, strengthen the weakened cornea by increasing thickness, maintaining the corneal contour, significant visual improvement, amelioration of symptoms. Surgery per se is quite simple, short, smaller learning curve, less invasive, less painful, sutureless and less trade-related complication, and all therapeutic grade corneas are required. In the start of surgery, corneal scraping done, stent with tryphan blue dye, then stromal emphysema created, then partial tryphanation done. Bowmans membrane is separating by using blunt and sharp dissection. Then Bowman's membrane peeled and cut with corneoscleral seizure. Then conjunctival resection is done with help of corneoscleral seizure. Cauterization of vessels. Then making a recess under the anterior 1/3 of stroma. And Bowman's membrane fastened up according to size of defect. Then tucked under the ulcer margin and recess. And BCL put for quicker epithelialization. In left side, this is another video. In right side, we can see ocular surface stability. Post-operatively, all patients were prescribed eye drop moxifloxacin, eye drop carboxymethyl cellulose, eye drop atropine sulfate, oral steroid, NSAID, vitamin C, doxycycline, and all patients were followed on post-op day 1, week 1 to 4, and 3 and 6 months. These are the reference. Thank you. Yes, sir. Yes, sir, it remains stable. Sir, 2 years. Yes, sir. Yes, sir, in all cases.
No, how did you control the inflammation?
Ma'am, 17 to 20 micron. Anterior stroma, yes, ma'am.
No, the inflammation is the main reason for this, the melting. How did you control the inflammation? You have put a Bowman's membrane as a scaffold there, and it has enhanced the stability of the cornea. But how did you maintain it? Inflammation has to be controlled, and how long you have put these patients on steroids post-operatively?
Sir, it provides scaffold and provide a region growth, and conjunctival resection was also done, and then it helps in reduce inflammation. So.